start, Vaishali?
Yes, sir. Yes, please.
Yeah, good evening, everybody. On behalf of the organizing committee for the focus studies in breast cancer, I welcome you all and wish you all a very, very happy, healthy, and prosperous new year. I am very happy to announce that this is our 24th webinar in the series, and the response has been more than expected. The credit goes particularly to my younger colleague, Dr. Vaishali, Dr. Prekshi, Dr. Safalta, Dr. Chirag Jain, and of course, the visiting faculty and the delegates and the MICE ideas. I hope that next 1.5 hour, you will enjoy the academic feast given to you by our learned faculty. And we promise you that we will continue this series with the same enthusiasm and maintaining the same standards in the future also. With this, once again, with a hearty welcome, I hand over the mic to Dr. Vaishali to start the webinar.
Thank you, sir. Once again, a very warm welcome to the faculty members as well as to the attendees. It's Lodi today, and I actually bring the best wishes for Lodi as well as Makar Sankranti to all of you. To begin with, let me invite my colleague, Dr. Prekshi Chaudhary, who is a senior consultant in radiation oncology at Max Hospital, Vaishali, to give us a brief overview of breast cancer in the elderly and why we should be treating it differently. Over to you, Dr. Prekshi.
Thank you, ma'am. So are my slides visible?
Yes.
Yes.
Good evening, everyone. So in the next few minutes, I'll be giving a brief overview as to why we have chosen this topic for discussion today. Breast cancer, yes, it is the most common cancer among women globally. Cancer is a disease of elderly, and our population is aging. By linking all these statements, we can make out that we are going to see more number of elderly breast cancer patients in near future. The slides are actually not moving. Yeah, it's going. Okay. So do we have any proper definition? What is elderly? Is there any cutoff age or threshold for that? So actually being elderly is a very subjective concept and it varies from culture to culture. Yes, some definitions have been advised, as NCCN says that 65 years or older is considered as elderly. IACT, that is International Society of Geriatric Oncology, has fixed this age to 70 years. But it is not the chronological age, and everywhere it has been emphasized that it is the functional age of the patient that is important in decision-making for the treatment. Also, this age is lesser in the developing countries as compared to the developed countries. So the thing which I was talking in the first slide, this is the supporting statistical data for that in the near future, we are going to see more number of elderly breast cancer patients. So the number is more. Are they different from their younger counterparts? Yes. It has been observed that in many cases, they experience delay in diagnosis. And in many of the cases, they also receive undertreatment. So why is the delay in diagnosis? So these patients are usually, in many of the cases, they are non-compliant to the treatment. They have multiple comorbidities and the treatment cost is obviously higher. So taking in view these things, they are often excluded from the screening strategies. Most of the screening, they have considered the age till 69 to 70 years of age, and some have extended this age to 74 to 75 years, not beyond that. So a delay in diagnosis has been seen in these patients, and around 48% patients who are more than 65 years of age, they often present with metastatic disease. In many of the cases, they receive undertreatment, and in few cases, yes, they receive overtreatment also. And most of the studies, they have excluded the elderly patients so that we don't have solid evidence to support the optimal treatment strategies in this subset of patient. Also, they have poor performance status, associated comorbidities are there, they lack social support, they also face difficulty with transportation, they have concerns about quality of life, and many times the patient and family preference, because of the lesser life expectancy, is not to proceed with the treatment. The tumor biology is also different from the younger patients, and they have less aggressive tumor subtypes. They have lower proliferation indices. Mostly they are ERPR positive, HER2 negative. Chances of lymph node involvement is also less. And as compared to the younger patients, they have the chances of having a favorable histology in the form of lobular mucinous and papillary carcinoma are on a higher side as compared to the younger population. However, it has been seen that in the last few years, the elderly patients, they are having more aggressive tumors, and around 15 to 18% of them, they have triple negative disease. So intrinsic biological characteristics should be considered. It is not only the age, the molecular subtype should be considered before we start with the treatment. As the age increases, the chances of comorbidities are increasing, and they have many comorbidities, and it has been seen that who is more than 70 years of age, they have on an average 3 or more comorbidities. So they should also be taken into account while treatment decision making. Another important thing is that the elderly patients are frail. And what is frailty? Decreased reserves, which makes them more susceptible to stressors and adverse outcomes. So it is better that before starting the treatment, we stratify these patients into fit, susceptible, and frail. So the elderly patients who are fit, they can undergo standard treatment protocols similar to that of the younger patients. Susceptible patients, they sometimes need geriatric assessment, and they also need treatment adjustments. Frail patients usually need tailored approaches with a special focus on supportive care. So while we make the treatment decisions, it is not only important to consider the breast cancer recurrence risk, but also to assess the competing risk of mortality. NCCN and ESCO recommend that these patients should be assessed, their life expectancy should be assessed, and there are calculators like e-prognosis, which can further assess these patients. So how should we approach in elderly breast cancer patients? So all the patients who are elderly breast cancer patients, they should undergo pre-treatment evaluation. Their functional age should be assessed and the underlying frailty. After that, we should proceed with the decision making. Comprehensive geriatric assessment is a very useful tool in these patients, and it assesses various parameters like functional status, comorbidities, nutritional status, medication, socioeconomic status, and geriatric syndromes. By assessing, by this geriatric assessment, we can have a comprehensive treatment plan and for the management as well as for the follow-up. It also assesses the comorbidities and various deficits. Sometimes what happens that only by history and examination, it is not possible to evaluate all the deficits which the patient is having. And by a CGA, we can have some additional information. CGA actually is a very exhaustive tool, and it is not possible to apply this tool in all the patients coming to the clinic. So various screening tools have been advised. These are the screening tools advised by NCCN, and among them G8 is the most validated and most sensitive questionnaire. So a two-step approach has been proposed. All the patients who are coming, elderly breast cancer patients, they should undergo G8 screening. The patients who are found fit on G8, they should undergo standard treatment protocol. And those who are unfit or frail, they should undergo further in-depth evaluation with the help of CGA. And those patients who are found optimum, who are found appropriate, they should undergo optimal treatment strategies. So these are the various domains like comorbidity, social functioning and support, cognitive assessment, psychological assessment, nutritional and polypharmacy. Various tools have also been advised, and proper intervention whenever required should be done. So this is a very nice paper by which was published in Lancet Oncology in 2021. The International Society of Geriatric Oncology and USOMA have recommended the management of older breast cancer patients, and they have covered various aspects related to the same. So by this, I want to conclude that the management of elderly breast cancer patients is challenging because the population is very heterogeneous. They have different needs. The decision making should not be, it should not be done only by the chronological age. Functional age definitely should be taken care of. They definitely should undergo geriatric assessment. And while making the decision, we should also consider patient preferences, life expectancy, survival benefits, quality of life, etc. In the subsequent sessions, we'll hear to our experts talking about the various cancer-related modalities. So, thank you.
Thanks, Dr. Brekshi. So Dr. Brekshi has given us a broad overview of the topic, and now we will move on to the individual treatment modality. And to begin with, I would like to invite Dr. Sanjeev Kumar Agarwal, who is the Senior Consultant and Oncoplastic Breast Surgeon at Tata Memorial Center, Kolkata, to talk to us about the surgical management of breast cancer in elderly and whether we need to have a different approach in their management. Over to you, sir.
Thank you, Dr. Vaisali. Good evening to all, and wish you all a happy and prosperous new year. And thank you, Dr. Rajiv, too, for inviting me and the whole scientific committee here. So can I share my screen?
Yes, sir, please. Yes, we can see it now.
So the topic for today, for me, I will focus specifically on the surgical part, because I think the next two speakers are covering the systemic therapy and the radiotherapy. It's a very interesting topic. So when I looked upon many myths of myself, I have cleared because you have given me this topic. I will try to put whatever I will say, I will try to put the evidences behind it, why I am saying this, and how we should follow the breast cancer surgical management in elderly group. So as said by our previous speaker, we don't have any definition, clear-cut definition, but as a nutshell, what as a cancer community feel that elderly people are defined as more than 65 years of age. Coming to the India, so we don't have any population census after 2011. So this was a US prediction of the Indian population. And if you see that how many people are there above 65 years in India. So in the population pyramid, it's up, and it's around 3.2 crore of people in 2020. So this is the projected figure of elderly people in India itself. Coming to what are the common consensus about breast cancer in elderly. So if you see the Western data, the nearly 1/3 or 40% of the breast cancer is being diagnosed after 65 years. As said by previous speaker, there is a lack of level 1 evidence because it's our feeling that clinical trial have excluded these group of the patient, but I will come into the subsequent slides. What's the reality for the surgical trials? It has favorable tumor histology, presents with larger and advanced tumor, and it has undertreated as per the accepted guidelines because of the fear of having comorbidity and not accepting the complete treatment. So coming to this breast cancer trial exclusion criteria, so I was looking upon the literature itself. So in how many trials? So this was a very good study which was published by epidemiology group in 2022 itself. And if you will see that in the breast cancer specific trial, they have included majority of the practice changing trial, and no upper age exclusion was there in 27 out of around 40 study, and it was 67.5%. So around 2 out of the 3 study has no upper age exclusion criteria, and it were majority of the surgical study. So if you are considering on the surgical study, probably elderly people have been included or has been included in the majority of the practice changing trial. Coming to what's the India situation. So this is the Western data that breast cancer age distribution more than 65 year age, 40% of the patient. But we all know that India is a country of young people. So this I looked up on the age distribution of breast cancer. What's the publication from the India, or what's the data from India? So this is not changing from the 2008 to 2017. So these are the 3 study which have published about the specific breast cancer incidence in elderly. And if you see the incidence in India, first study was epidemiological study was published by Dr. Gaurav Agrawal from Lucknow. And in his study, the population percentage of elderly was 20%. Second study was published again by a epidemiologist, and it was 23%. This third study was specific for the Delhi epidemiology study, and again it was 20%. I have looked up on our data too. So TMC data also, it shows that the breast cancer in elderly is 18.7%. So if you compare the Western and Indian population, probably we are seeing half of the elderly patient. It's not 40%, it's 20%. But is this a huge number? So yes, it's a huge number, because if you go as per the WHO data 2020, so if you cut out the 20% of the patient, so probably 35,000 of new breast cancer, which will be diagnosed above 65 years in India. That was the projection for 2020 by WHO or Globocare 2020. So as age progresses, there is a famous Dutch study. What's changing? So this was an observational study, and this study tried to study the practice pattern or the stage pattern, how the elderly patients are treated differently than young patients. So if you can see here the as we said that stage 2 disease. So yellow box is stage 2 disease. So stage 2 disease is increasing from young to elderly population to 32%. And stage 3 disease is changing from 8 to 18%. So this study was the first study which has quoted that the breast cancer stage in elderly patient is generally of higher stage. Continuing to the study finding, if you see that in the first row, surgery in all tumors, so you can see that the surgical management generally decreases with the age, with the many myths that surgery may have the wound complications, surgery may have more seroma formation, and surgery may deteriorate the patient quality of life, or it may be the surgery can give the mortality to the patient. So why to operate? And it's there in developed country too. So surgery in all tumor is generally decreased from 99.2% to 41.2% in 90 plus year of elderly lady. Coming to the mastectomy, so mastectomy generally increases. So if you see the 15 to 64 year, how many patients were offered or have done mastectomy? It's around 45%. But if you go to 90 plus, you see that the percentage of the patient having mastectomy is 76.2%. In the contrast, if you see the lymph node dissection, it decreases with the age. So 15 to 64, 66.2%. And in the 90 plus age, it's 99.9%. Same thing for the systemic treatment too. So any adjuvant systemic treatment generally decreases from 78.5% before 65 to 53.3% in 90 plus. So these are the observations about how the treatment is changing with the elderly population compared to the young population, and how the stage is changing. To summarize, so generally in the elderly population compared to the young population, so I am saying about more than 65 or less than 65, generally these 4 things decreases: breast conservation surgery decreases, axial lymph node dissection decreases, radio and chemotherapy decreases. As per the data, there is no difference of offering hormonal therapy in young lady or the elderly lady. as said by the previous speaker, substandard treatment is very prevalent in the elderly age, considering chronological age in healthy elderly female. And we all misunderstood the life expectancy, and we really need to focus on comprehensive geriatric assessment tool to see the physiological age and decide upon the treatment based on the physiological age rather than chronological age. So these are the challenges in decision making, which was already covered by the ex-speaker. So we try to think for physiological age. The cancer trial have excluded elderly people, and there is no level 1 evidence. We all know that in India, at least, medical insurance is not available for the majority of the elderly people. Social funding, so even social funding is more concentrated in the young people. Comorbidities is a significant issue in the elderly population, and the decreased life expectancy is also a major issue there. So is there any benefit of surgery? So we all say that, is surgery beneficial in elderly or not? And if we are doing surgery, what's the survival benefit? And if we are doing surgery, are we increasing mortality due to the surgery itself? So so this is the data published, and as per the data itself, surgery related mortality is very low even in elderly breast cancer patients. So don't fear to give option of the surgery in elderly breast cancer patient. It's 0 to 0.3% that the breast cancer surgery is specific mortality in elderly group of the patient. There are a few trials in the initial stage which compared the two groups. So in elderly breast cancer patient, ER positive patient, either give tamoxifen or do surgery. And in the initial trial, what mistake was done? So the comparison was between tamoxifen and surgery, and it was found that the survival is equal in both the group, and there is no difference in survival if you are giving tamoxifen to the one group or surgery to the one group. But this study had changed, the last study in the table had changed the whole concept that surgery is really beneficial if you are combining it with tamoxifen in the ER positive breast cancer. So you can see the survival here in the tamoxifen only group in elderly ER positive breast cancer is 28.1%, and in the surgery and tamoxifen is 37.7%. So with this, after this trial publication, in the majority of the Western country, also people were more comfortable in offering surgery in very elderly group of the patient also. So the same study, you can see the gross difference between the disease-free survival and some difference between the overall survival between the two groups. So coming to the surgical management itself, so this was a UK study. So when we operate, we have the fear of having more surgical complication, decreased quality of life, and perioperative mortality in this group of the patient. So is it true? So this is the UK data analysis, and you can see here the perioperative mortality in around 3,375 patients was 0% in this. Perioperative mortality was calculated up to 30-day mortality rate. Complication, it was 1.4% surgical complication overall in BCS and Sentinel group, and 2.9% in mastectomy in ALND group. So fairly acceptable. And we see the same complication rate in young breast cancer patient too. What are the wound complication rate? So both minor and major, they have included, and it was 18.4%, again comparable to the young breast cancer patient. Seroma rate, it was 25.4%. Yes, there was a little bit marginal negative impact on the quality of life and independence, majority in the mastectomy in the ALND group in this study. Can we do breast conservation surgery? Yes, we can do breast conservation surgery safely. So this was the study which was a meta-analysis of 3,000 patients, and 5-year local recurrence was only 2.3%. We can omit radiotherapy. I'm not going intentionally to the radiotherapy. It will be covered by the next speaker. Can we do oncoplastic and reconstructive breast surgery if patient want to? Yes, answer is yes. This was a study which compared the cosmetic outcome or the patient-related outcome by breast Q questionnaire between the two group of the patient. One is older patient and second is younger patient. And I was surprised to see the results. So cosmetic satisfaction rate was higher in older patient for oncoplastic and and reconstructive breast surgery compared to the younger patient. So physical well-being score was median was 88.05 with a standard deviation of 16.3 in the older patient, and in the younger patient it was 75 with the statistical significant difference in physical and psychological well-being. So auxiliary staging, do we need to do auxiliary staging? So this was a population-based study which was published recently. So they have included 1,044 patients from the National Cancer Database, and they have seen the survival between the two groups. So around 22,000 patient auxiliary staging was not done, and around 1,21,000 patient auxiliary staging was done. And OS for the patient where omission of auxiliary staging was done was significantly higher compared to the patient who have received auxiliary staging. And these are adjusted hazard rates, so means adjusted for the age, comorbidities, and the stage and the nodal status of the breast cancer. So again, the auxiliary staging, if the patient want and if you can do the auxiliary staging safely, ideally you should do auxiliary staging even in elderly breast cancer patient. What about node negative early breast cancer? So if you are doing auxiliary staging, you can do sentinel lymph node biopsy by dual dye. Methylene blue and ICG, if you are doing, you need to think for the comorbidity, just like renal failure in the methylene blue and the liver compromised function in the ICG. Can we apply G11 and Ambrose criteria for the surgeon? Yes, because G11 and Ambrose, although the population group represented was very less for the elderly breast cancer, but if your institution is following the G11 and Ambrose, these two trials have not excluded the elderly patient from their inclusion criteria. There is some amount of data for omission of sentinel lymph node biopsy in more than 70 years of age of patient. This is a meta-analysis which was published for 2 randomized controlled trial, which was done in this setting. There is a statistical significant increase in axillary recurrence with no difference in survival and decision making. But if you are thinking for omission of sentinel lymph node biopsy, as per the RCT inclusion criteria, these are very selected group of the patient greater than 70 year, T1N0 disease, and having multiple comorbidities. What's the data for the neoadjuvant chemotherapy? So what's the difference between elderly versus young? So as a surgeon, we decide upon neoadjuvant chemotherapy if we want to de-escalate the surgery. So this was a very good study which was published again in 2022. So you see the anthracycline-based regimen was less used in elderly patients. So 69% versus 93%. Completion chemo was only 57% versus 78%. So only 57% of the elderly people have completed their chemotherapy. But once you go to the surgical de-escalation, so you can see the BCS eligibility was there in 72% of the elderly patient with no difference compared to the young breast cancer patient. Omission of the ALND, it's same. Although this study has quoted that low PCR in TNBC in ER positive HER2 negative breast cancer patient compared to the young breast cancer patient in contrast with the elderly patient. Can we offer NAET in HER2 positive HR2 negative breast cancer? So if you see the data, this was a recent study published in the JAMA. What the study quoted, and it's a very nice study. It has changed the thinking of many people, many surgeons around the world. So if you see that the equal breast conservation and axillary preservation rate, but if you compare the survival of NACT versus NAET, there is a significant deterioration of survival even in the elderly patient who are receiving NAET instead of neoadjuvant chemotherapy if they are fit to receive chemotherapy. You can see here neoadjuvant treatment, NACT compared to NAET. NAET has poor survival with adjusted hazard ratio of 2.67, and this holds true in all the age. So if you compare 20 to 49, 50 to 59, 60 to 69, and 70, hazard is never going less than 1, or it is not having a significance considering the age. So if the patient is fit for NACT, as per the recent findings, you should consider chemotherapy rather than endocrine therapy in this group of patients. So conclude, I should say that surgery should not be denied to elderly. Procedure should not differ based on the age if the patient is fit for having treatment. BCS and auxiliary staging should be preferred because we have seen the good quality of life with the BCS and sentinel lymph node biopsy in elderly group of the patient. Under treatment should be avoided unless indicated, and clinical trials should include all age group for reliable data on elderly. So thank you, and I'm happy to answer any question in the chat box.
Thank you, sir. In fact, we will be taking the question answers during the panel discussion. So I would request you to please stay on.
Yeah,
And we'll move on to the medical oncology part of this webinar. It is my pleasure to invite Dr. Chirag Desai, who is a senior consultant and in the Department of Medical Oncology and is a director of Hemato-Oncology Clinic Vedanta at Ahmedabad. Welcome, Dr. Chirag, and over to you.
Thank you very much. Can I share my screen?
Yes, sir.
With the webinars going on, we have got the habit of asking in the face-to-face meeting as well whether I am visible and whether my slides are visible. I hope my slides are visible.
Yes, sir. Yes.
Thank you. So, a very good lectures by the previous two speakers. A good overview by Dr. Prakshi and excellent discussion about surgery in elderly patient by Dr. Agrawal. So I will be talking about the optimizing systemic treatment for geriatric breast cancer patients, and I will be including the adjuvant, neoadjuvant as well as metastatic disease. So systemic therapy is an important component of breast cancer treatment. It can be neoadjuvant, adjuvant, or for metastatic disease, and the systemic therapy can be hormone, anti-HER2 therapy, chemotherapy, or targeted therapy. In younger versus older patient, and that is going to be the theme of my presentation today over next about 12 to 15 minutes. So this is the introduction of the same paper which Dr. Prakshi showed. It is the guideline of USOMA and CIOG in 2021, and it only shows that we are going to confront more and more elderly patients with early as well as advanced breast cancer in coming days. So we will need to be prepared with evidence-based treatment for these patients. So this was a paper from Singapore, and it showed that survival from the 4 years of 2004 to 2008 compared with 2009 to 2013 in various ethnicity in Singapore has been increasing. But if we look at the survival in the different age groups, as we can see here, in the younger patient versus the older versus the eldest patient, beyond 74 years, the survival is sharply diminishing. From 2004 to 2008, it was 46.34%, while for 2009 to 2013, it was 53%, while it was 89% for the younger patient. So survival is decreasing. And if you look at the biology, not huge difference between Asian, there is a Chinese population, and Vienna, that is the Caucasian population. ER positive, 73 versus 84%, a little higher in Western population. PR positive, again 66 versus 60%, little higher in the Chinese population. HER2 positive, 5.9 versus 9.7%, and triple negative, higher in the Asian population as compared to Caucasian population. So some difference in the biology in the elderly patient. And there was the conclusion of this paper. I didn't show some of the slides of this presentation, that elderly patient usually present with late stage disease, patient delay, higher prevalence, less screening, more fatalistic view, lower awareness of breast cancer, etc. are the reasons for that. Irrespective of the ethnicity, elderly patients are more likely to present with ER positive tumors, but less likely to receive chemotherapy and radiotherapy because of various reasons. And the reasons given in that publication were comorbid condition, limited life expectancy, assumptions that breast cancer is less aggressive in older women always, and decision based on toxicity profile of the drug and comorbidities, patient and families' wishes, and financial and cultural reasons. So had a poor overall survival, but the difference were reduced on stage to stage stratification. So what do we mean by older adult? And NCCN guidelines show that it's 65 years beyond which the chronological age is considered to be older age. And we also need to look at the biological age, as the previous two speakers have already discussed, and I will not go into the details of that discussion. There are few articles which I have selected from which I have made my presentation. This was the 2016 publication from Czech Republic. This was the review article from Saudi Arabia, but that was the 2022, and it is covering all the updated literature. And the initial USOMA CEOG guideline was in 2017. Then this one was in 2012, and this was as shown by Dr. Prakshi. The latest one is in 2021. These are the updated recommendation regarding the management of older patient with breast cancer. And most of my references I have taken from this publication. So it shows that, look at the middle white line, competing cause of mortality. This is important, that even in the absence of multimorbidities, competing cause of mortality are more prevalent in the older adult compared with the younger adult counterparts. And treatment decisions for anti-cancer treatment should be based only on the risk of recurrence or breast cancer mortality, but also weigh the risk of dying of other causes, which are equally important factor in our decision making. So if we look at the neoadjuvant chemotherapy, so neoadjuvant systemic therapy is effective similarly to the younger women, and for the fit, carefully selected older patient, we should utilize systemic therapy as neoadjuvant therapy as good as in the younger patient, but less fit older patient are best served by surgery upfront that could enable the systemic treatment de-escalation based on the pathological finding and physical recovery after surgery. It is also written that sequential regimen with anthracycline and taxane can be considered in principle because of the aggressive phenotype in triple negative or high grade tumors. But we should keep in mind that the toxicity is higher and shorter treatment regimen of less than 6 months is also adequate for some of these patients. Addition of platinum compound in triple negative is controversial even in the younger patient. We had a nice publication from TMH in this San Antonio Breast Cancer Symposium, but platinum compounds add to the toxicity and adds very little to the efficacy in older patients. If the patient does not achieve a PCR in a TNBC after neoadjuvant therapy, capecitabine in case of residual disease is recommended for fit older patient. And for HER2 positive patient, neoadjuvant therapy should be followed by TDM1 for the fit patients. Neoadjuvant endocrine therapy, if given for the frail patient, it should be given at least for 4 to 6 months to be useful. Shorter courses are not so very useful. And letrozole or any of the aromatase inhibitor is favored over tamoxifen because of the better response rate. So if you look at the primary endocrine therapy, avoiding surgery altogether and giving only endocrine therapy, whether it should be done, whether it is feasible, whether it is useful. So when primary endocrine therapy involves aromatase inhibitor, the median time to progression is approximately 5 years. So if the patient's life expectancy because of the comorbidities is less than or equal to 5 years, there is little benefit of surgery. I'm sure Dr. Agrawal will have some arguments against this statement, but there are several publications where there is very good progression to survival with aromatase inhibitor if it is given as a primary endocrine therapy. The benefit of PET versus upfront surgery is expected to be most pronounced in patients with life expectancy of less than 5 years. If the life expectancy is more than 5 years, surgery followed by appropriate treatment is something that should be done. So how do you know whether the patient is going to survive for shorter or longer than 5 years? And there are various tables, various algorithms to calculate the life expectancy. So at every age, at the age of 70, 75, 80, 85, and so on and so forth, if the patient is in the best tertiles, this is the life expectancy in the black bar. If in the middle tertile, this is the life expectancy in the middle bar. In the worst tertile, this is the life expectancy in the hollow bar on the right side. So as we see, after 70, 75, 80, 85 years, the survival chance keeps on decreasing, and that should be something which is to be kept in mind while we plan the treatment. And we also have to keep in mind the potential toxicity to various therapy, particular chemotherapy, and we have chemotherapy toxicity calculator, which I will be referring in the next slide. So HER2 negative adjuvant chemotherapy. So it should be given if the patient is fit enough, and the patient should not be denied of the potential benefit of adjuvant therapy. But the preferred duration is of 3 months and not longer than that. And that chemotherapy can be either CMF or adriamycin cyclophosphamide, which is slightly better than CMF, or docetaxel and cyclophosphamide, which is better than adriamycin cyclophosphamide. Weekly paclitaxel can be an option if the patient is unfit for polychemotherapy in carefully selected fit patients. And it is also written that dose dense regimen, 2-weekly chemotherapy should not be used in elderly patient because of the higher toxicity. So comprehensive genomic, not genomic, but geriatric assessment should be done for this patient. And there are various publications, there are various ways in which we can do the geriatric assessment. There are various tools, but the most frequently used, not in our country, not in my practice, but world over, is abbreviated comprehensive genomic, not genomic, geriatric assessment. I'm very much fond of doing genomic assessment, but it is geriatric assessment in this meeting. So CGA versus ACGA. So CGA, comprehensive geriatric assessment, takes about 45 to 50 minutes, and which is difficult to perform in busy OPD. So abbreviated comprehensive geriatric assessment, which comprises of medical history, clinical examination, performance status, cumulative illness rating scale, and a nurse can do various things like activities, daily living, instrumental ADL, mini nutritional assessment, and so on and so forth. And this takes on an average about 10 minutes to perform. And this is doable in our clinic as well. So we should form a habit. I don't do that routinely, and I confess that I perceive the need for doing the assessment formally. So multi-gene signatures have limited value in very old patients. It is not useful in very young patients as well. So I think multi-gene signature various, so whatever they are useful in 50 to 65 years of the patients only. So integration of information regarding the general health status in multi-gene signature is something which is essential, and that should tell us whether patients are fit for surgery, not surgery, for chemotherapy, or patients are going to be benefited with chemotherapy over the endocrine therapy or not. So adjuvant HER2 therapy, one of the good option for HER2 positive early breast cancer is 4 cycles of docetaxel cyclophosphamide or 12 weeks of weekly paclitaxel along with 1 year of trastuzumab. Pertuzumab can be added only in high risk and fit patients, but diarrhea can be debilitating for this patient with addition of pertuzumab. If the patient is frail, only trastuzumab also is an option. And shorter trastuzumab has not been validated in elderly population, but it can be given in context of cardiac problems that the patient cannot take the entire year of trastuzumab therapy. So these are the guidelines that chemotherapy in HER2 negative early breast cancer, adriamycin cyclophosphamide 4 cycles, CMF 6 cycles, or TC for 4 cycles, it is validated in older patient. Weekly paclitaxel for 12 cycle, it's the option who are HER2 negative and high risk. Sequential azacitidine and taxane, we don't have good data in older population. Capecitabine or weekly docetaxel, we don't have any data. We should not give that therapy to the older patient. And prophylaxis with GCSF should be recommended in a patient with risk of neutropenia even less than 20%. For HER2 positive patient, as I already said, 4 cycles of TC plus trastuzumab, weekly paclitaxel for 12 cycles plus trastuzumab is recommended. TCH 6 cycles has not been tested in older patients and probably not suitable because of the high dose of carboplatin and high toxicity and possible mortality as well. Trastuzumab without chemotherapy, I already discussed. Pertuzumab, high chances of diarrhea, and lenient use of GCSF is important. 1 year of anti-HER2 therapy or shorter duration recommended for N0 patients. Adjuvant endocrine therapy should be given to the patient who need endocrine therapy. Aromatase inhibitor is better than tamoxifen. Longer duration beyond 5 years of tamoxifen is recommended, or only 5 years of aromatase inhibitor is recommended. We should keep in mind the higher chances of arthralgia, myalgia, osteoporosis, cardiovascular risk, and fracture risk with aromatase inhibitor, and DVT as well as pulmonary embolism risk with tamoxifen, and that has to be carefully selected. If the patient is having T1A N0, patient can be only observed without giving any endocrine therapy. That is also good enough. Now, for metastatic breast cancer, we know that these patients are not going to be cured, and we don't want to harm this patient by giving the treatment if it is not going to help them. So particular care should be paid, avoiding treatment-related toxicity. Monotherapy is always preferred over polychemotherapy if the patient is not having very aggressive disease. And there is data that single drug nab-paclitaxel or eribulin is well tolerated in older patients. HER2 therapy for metastatic breast cancer, so anti-HER2 trastuzumab with a taxane and preferably paclitaxel, not docetaxel, in elderly patients. Pertuzumab can be given a high chance of diarrhea, I already said, in adjuvant therapy. If the patients are hormone receptor positive, patients are doing good enough with anti-HER2 therapy with endocrine therapy. We have good articles for that as well. And if the patients are unfit for aggressive chemotherapy, anti-HER2 therapy with metronomic cyclophosphamide or vinorelbine or capecitabine, also we have some data. So we have to be careful in treating the patients who are frail. Targeted therapy, we have data of all three CDK4/6 inhibitors, its utility in elderly patients who are fit to take this treatment, but we don't have the data for the drugs like alpelisib in elderly patients. Use of everolimus should be approached with caution on case-to-case basis because of the worst safety profile in the elderly patient in Bolero 2 study. Drug safety and compliance is something that should be kept in mind when we are offering the treatment to the elderly patient. And as I alluded to earlier, chemotherapy toxicity calculator, there are two different set of calculator. One is CARG chemotoxicity calculator. Another is CRASH tool, which keeps in account patient-related factors, the tumor-related factors, treatment-related factors, laboratory values, geriatric assessment variables, and so on and so forth. They should be kept handy when we are treating the elderly patient with metastatic disease. So this is the famous line on the first page of Hutchinson's book of clinical medicine, which we were reading in early MBBS days. Look at the last line, that from making the cure of the disease more grievous than the endurance of the same, good Lord deliver us. So keeping that in mind, age is an issue of mind over matter. If you don't mind, it does not matter. We have to treat the patient appropriately, but judiciously. Thank you very much.
Thank you, sir, for that lucid presentation. And I'm sure all the attendees are definitely benefiting by your presentation. Again, a sincere request for you to stay on with us for the panel discussion. And we'll take the questions if there are any at that time. So moving on, it's my pleasure to invite my dear friend and a colleague, Dr. Vinita Goel, who is the director and head of the Department of Radiation Oncology at Fortis Hospital, Shalimar Bagh. She's going to talk on radiation therapy in geriatric patients is less more. Welcome, Dr. Vinita.
Thank you, Dr. Vaishali. Just give me a minute. I'll just start sharing my screen.
Sure.
Vaishali, are my slides visible?
Yes, yes.
So thank you, Dr. Vaishali and Dr. Goel, for inviting me for this important webinar. Since you have allotted me only 15 minutes, so I'll be restricting myself to talk about the role of radiation therapy for early breast cancer in geriatric population. Less is more. So I agree with you that the topic that you have chosen is a very relevant topic. This is one graph that I wanted to share with everyone. This is a SEER database, which shows the incidence of new breast cancers by age group, and which clearly reflects that about 43% of the breast cancers occur in the age group of above 65 years. And we need to find specific solutions for this group of patients. As we all understand, I'm talking about breast conservation therapy, that as breast conservation therapy became an accepted mode of treatment, there was always a quest to identify women who are at low risk of breast cancer and where we could avoid post-operative radiation therapy safely. And majority of the older patients, not everyone, but majority of the elderly patients have HR positive indolent tumors. So this is the group where avoidance of radiation therapy has been studied for a longest time. I want to take you through this trial, which is also known as CalGB trial. This is a trial which got published in 2005. It was considered a practice-changing trial. It enrolled 636 women, more than 70 years of age, with early breast cancer, T1N0, hormonal receptor status positive, and all these patients underwent lumpectomy with clear margins. For unknown reasons, axillary lymph node dissection was allowed, but was rather discouraged. If you just look into this table, that about 60% of the patients did not have an axillary clearance. These patients who had T1N0 breast cancer, they were randomized to tamoxifen alone versus tamoxifen plus conventionally fractionated whole breast radiation therapy and boost. And the primary endpoint of this trial were time to locoregional recurrences, rates of mastectomy done for local recurrences, distant metastasis, and overall survival, with the secondary endpoint of cosmesis and adverse effects. The hypothesis which this trial was trying to prove was that the EBC-TCG meta-analysis showed that postoperative radiation therapy in breast cancer improves survival only when the ipsilateral breast tumor recurrence is more than 10%, while newer studies were showing that in spite, because of a lot of improvement in surgical techniques, IBTR rates are less than 10%. And older women with smaller tumor are likely to have lesser recurrences. On top of it, we are giving all these patients tamoxifen, which will also decrease the risk of IBTR. And anyway, these older women have other competing risks of mortality, and their life expectancy is not very high. With this in mind, this trial tried to assess the role of radiation therapy added to hormonal therapy in this early stage breast cancer patients. In 2005, the study published their 5-year results, where the local recurrence rate was 1% in the radiation arm plus tamoxifen arm versus 4% in the tamoxifen alone arm. Now, the time to mastectomy after recurrence was not different between the two arms. The reason why this time to mastectomy, which was another primary endpoint of this study, was not different between the two arms was because the 8 women in the tamoxifen arm who had recurrence, they underwent repeat lumpectomy followed by radiation and not mastectomy. So probably I think the endpoint should have been the need for salvage surgery rather than mastectomy. The overall survival, as was expected, was similar across both the groups. We all know that radiation therapy improves overall survival after a long follow-up of 10 to 20 years, and this was a result available at 5 years. Patients in this study were having very early breast cancer, and they had several other competing causes of mortality. So to get overall survival benefit out of radiation therapy probably required a much larger sample size, and this sample size of 636 was probably not adequate. So the authors of this study, they concluded that addition of adjuvant radiation therapy to tamoxifen does not decrease the rate of mastectomy for local recurrence, does not increase the survival rate, or does not increase the rate of freedom from distant metastasis. They conveniently forgot to mention about the local recurrence advantage of radiation therapy. So that they said that for the above reasons, tamoxifen alone is a reasonable choice for adjuvant treatment in such women. Patients and their physicians should weigh the slightly increased risk of local recurrence against the cost, inconvenience, and adverse effect of radiation therapy. And the choice of treatment should take into account the needs of the patient, and both options appear to be appropriate for this group of patients. This trial was further followed, and in 2015, 10-year results of this trial were published, and radiation therapy continued to show benefit. At 10 years, they showed that the freedom from local and regional recurrences was 98% in tamoxifen and radiation arm versus 90% alone in tamoxifen alone arm. However, there were no differences in the other endpoints of the trial. Now, if I just want you to go through this pattern of failure in this study, if you look at the IBTR, ipsilateral breast tumor recurrence rate, it was almost 10 times more in the arm receiving only tamoxifen. Axillary recurrences were not known in the tamoxifen plus RT arm, while 5 patients had that. I also want to highlight that if you look at the deaths among the patients, then the breast cancer specific mortality was far less in these patients. They were probably dying of other causes other than the breast cancer. If you look at the adverse effect profile, which was the secondary endpoint of the study, then the adverse effects of tamoxifen were not even assessed. The details of compliance to tamoxifen are not even mentioned. The breast pain, skin fibrosis, skin edema, they were certainly worst in the arm receiving radiation therapy. However, the grade of these toxicities is not mentioned. And as we understand, majority of these are self-limiting toxicities. I also want to remind you that this is an older study where quite a few patients were treated with telecobalt and 2D planning. However, in spite of all this, this is considered a practice-changing study. This is a SEER database analysis which looked at the use of adjuvant radiation therapy in elderly patients with early stage breast cancer, the change in the practice pattern after the publication of CALGB trial, and it showed that there was an 8% decline in the use of radiation therapy after this publication. However, I also want to emphasize that about 60% of the physicians continued to practice post-operative radiation therapy, and a large number still believed in the use of radiation therapy in early breast cancer. This is another very important trial from the perspective of radiation therapy. This is a trial on the similar lines where about double the number of patients, 1,300 women, more than 65 years of age, with T1, T2 tumors, ER-positive tumors, after breast conservation surgery, were randomized to any kind of hormonal therapy versus hormonal therapy along with radiation therapy. The maximum tumor size permissible in this study was less than 3 centimeters. Grade 3 histology and LVI were both allowed, but both these factors were not permitted together. Now, the primary endpoint of this study was again ipsilateral breast tumor recurrence, and at 5 years, again, similar local recurrence rates as compared to GALGB study. The IBTR rate was 4% in the endocrine therapy alone arm versus 1.3% in the RT arm, suggesting that there is a significant but modest reduction in the local recurrence. The authors of this study concluded that, however, the 5-year rate of ipsilateral breast tumor recurrence is probably low enough so that endocrine therapy can alone be considered in these patients, which is a very valid point. On multivariate analysis of factors predicting for local recurrences like tumor size, margin status, grade, age, LVI status, etc., they found that use of radiation therapy was the only factor which predicted decrease in the local recurrence as compared to rest of the other factors. Similar to CALGB study, PRIME2 trial also has its 10 years results reported 2 years back. 10-year local recurrence rate without radiation was 9.8% as compared to 0.9%. So there was almost a 10 times difference. I'm trying to emphasize on this because I think that at least women were using a lot of tools, we can assess that they have a reasonably long life expectancy in spite of being in a chronologic, in a geriatric age group. These patients probably would merit radiation therapy. This trial also divided the estrogen receptor positivity into low ER positivity versus high ER positivity. And they found that the patients who had low ER positivity, when not given radiation therapy, the 10-year local recurrence rates were 18.8%, which is way too high. I also want to bring to your notice that LVI was present only in less than 5% of the patients. Grade 3 tumors were only less than 3%. More than 2 centimeter tumors were only 12%. So 90% of the 90% of the tumors were ER positive as well as ER richly positive. So majority of these tumors had very, very favorable subtype, less than 2 centimeter, grade 1, grade 2, LVI absent. So probably if you rethink about avoiding radiation therapy in this subgroup of patients, make sure that your patients have all the favorable factors before you offer them only endocrine therapy. There are certain challenges with these two trials, both CALGB and PRIME2. Although radiation therapy was beneficial, but because the absolute benefit was very less. I also want to emphasize that the 10-year overall survival in the CALGB study is only 65% because vast majority of the patients were dying due to other causes. Life expectancy, geriatric assessment, comorbidity score, etc. were not evaluated in this trial. Both these studies were done in the era of conventionally fractionated radiation therapy, where radiation therapy was given over 5 to 6 weeks, and the importance of cardiac sparing was not fully realized and practiced while the study was being taken up. So I would say that based on PRIME and CALGB study, NCCN guidelines endorse that endocrine therapy is an acceptable alternative to radiation therapy in older patients with, favorable tumor profile. But I think there is a lot which needs to be done. These studies provide good starting points conceptually, but more studies are needed before completely calling off radiation therapy in this subgroup of patients. So on similar lines, I wanted to just share this SEER database with you, which looks at the influence of histological grades on outcomes of elderly women with early stage breast cancer treated with BCS, breast conserving surgery, with or without radiation therapy. Let me remind you that CALGB study did not report tumor grade at all, and PRIME study had only 3% women with high-grade tumors. This is a SEER database of women in the age group of 70 to 79 years. About 12,000 women were chosen who had T1 up to T1 tumor and 0 HR positive tumors. About 14% patients had grade 3 tumors. When they looked at the whole cohort, they found of grade 1, 2, and 3, they found that the overall survival was superior in the arm receiving radiation therapy as compared to endocrine therapy alone, both at 5 years and 10 years. When they did a stratification, they found that in grade 1, there was no difference in the cause-specific survival between radiation versus no radiation therapy, while in grade 3, there was a more pronounced benefit in 5 years as well as 10 years cause-specific survival with the addition of radiation therapy. So these are the survival curves which are demonstrating what I have just said. So there is an increased risk of breast cancer-specific death when omitting radiation therapy in elderly patients who have grade 3 disease despite early stage breast cancer. So one needs to pay caution, when taking these decisions. We oncologists often discuss about our own trials. Let's also look at this survey, which talks about experiences and perceptions of older adults with low-risk hormone-positive breast cancers about adjuvant endocrine and as well as radiation therapy. So this survey was served to about 130 women who had low-risk ER-positive breast cancer. 78% patients completed the survey. Of this total, 171% patients had received both radiation therapy and hormonal therapy. So they were given a questionnaire. For example, they were asked, which treatment impacted your quality of life? So 14% patients said radiation therapy, while almost 35% patients, which is more than double, said endocrine therapy impacted their quality of life, while 8% said both affected and 43% were fine with both the treatments. They were also given a choice as to which treatment would they rather receive, and 57% patients chose radiation therapy over endocrine therapy because we understand, as was mentioned by Dr. Desai also, that endocrine therapy does have disturbing side effects like arthralgias, fatigue, etc., hot flashes, etc. While with radiation therapy, majority of these side effects are transient and self-limiting. So what do we have as radiation oncologists to offer to these elderly women with early breast cancer? Can the radiation be made a little shorter, yet effective and safer? So I have, charted out made this table, which talks about the results of partial breast radiation therapy for some of these patients. These are 5 studies that I chose to present: Import-Load, Rapid, NSABP, APBI, and Florence study, as well as Jackie Stroh. All these 5 studies had patients with T1, T2, node negative, or N0, N1 patients. Majority of the patients were above 50 years of the age. These patients were treated with either partial breast radiation therapy or whole breast radiation therapy using various kind of techniques and schedules, 3D CRT, IMRT, as well as brachytherapy. And if you look at the IBTR rates, then the breast tumor recurrence rates are comparable in whole breast radiation therapy versus partial breast radiation therapy. And this is almost a data of 10,000 women with minimum 5 years follow-up. It suggests that partial breast radiation, either in the accelerated fractionation or conventionally fractionated schedule with any of the techniques, leads to equivalent local control rate and with significant reduction in the toxicity. This is just a dose wash, which is showing that only a part of the breast, only the area around the lumpectomy cavity is being treated, and the heart and the lung are largely being spared. The doses reported are 0.15 gray, 0.1 gray, and this is not a proton plan. The A plan is not a proton plan. This is a photon plan, the conventional IMRT IGRT plan. So partial breast radiation is effective, convenient, safer, leads to good cosmetic outcomes. What is stopping us radiation oncologists from practicing partial breast radiation? I would say, if you want to consider your patient for partial breast radiation therapy, then the radiation oncologists have to be included in the patient's clinical examination and decision-making right from the diagnosis, not after the surgery. My message to the surgical colleagues in the audience is that avoid oncoplasties indiscriminately. When needed, certainly one should do it, but some of these older women who have pendulous breast or atrophic breast may not always require oncoplasty. Even if you are doing one, then put tumor bed clips meticulously. My another recommendation is that don't offer MRM to everyone just to avoid post-operative radiation therapy. Do intraoperative or post-operative partial breast radiation. Discuss and offer breast conserving surgery to suitable women, because loss of body image post-mastectomy can sometimes lead to depression as well as low self-esteem. We are in the era of high precision short course radiation therapy. Radiation therapy, which was being delivered earlier in 6 weeks, now gets delivered in 3 weeks, and we are heading towards 1 week and a single day of radiation therapy. So this kind of short course radiation therapy may not be a very avoidable thing for a lot of patients. I'm sure everyone in the audience would have heard of this fast forward trial, which was published during the COVID times, multicentric phase 3 trial from UK, enrolling about 4,000 women, which compared 3 weeks radiation therapy with 1 week radiation therapy and showed that both were equally efficacious. So this can be an option for a frail old lady after breast surgery. Rather than avoiding radiation therapy, consider this form of radiation therapy. I also want to bring your notice to another very important trial, which is a little less talked about. This is called FAST study. The previous one was Fast Forward, and this is FAST. In the FAST study, again, a multicentric study from randomized study from UK, patients were given either 5 weeks of daily radiation therapy or once a week radiation therapy, every Saturday or every Monday for 5 weeks. And this study also showed that this weekly fractionation did not have adverse acute or toxicities or adverse cosmetic outcomes, while provided similar local control rate. If I look at some of the guidelines, then this is the RCR guideline, which strongly recommends offering 26 gray in 5 fractions over 1 week, to a good number of patients. And it also says that for patients who are not even suitable for 5 consecutive fractions, give them once in a week radiation rather than avoiding radiation therapy. A time might come where radiation oncologists might be treating breast cancers directly without surgery. For example, this is a prospective study which is going on. I'm sure this time is very far away. It might never come, but looks like that, some of these patients might benefit with this approach also. This is ablative radiation therapy. So in this is a MRI guided radiation therapy. Here patients undergo sentinel node first. And if the sentinel nodes are negative, then instead of surgery, directly a single fraction radiosurgery is delivered to the breast tumor while avoiding surgery, and the surgery is taken up after 4 to 6 months. There are several studies of stereotaxy which are evaluating 5 fraction to 1 fraction, all kind of fractionation for these patients. So radiation therapy options are quite wide: 3 weeks, 5 days, once in a week for 5 days, 5 weeks, or a single dose. All are largely safe. So I would say customize and choose wisely rather than avoiding radiation therapy. Endocrine therapy certainly is not an innocent player, has a lot of toxicity, and 15 to 30% patients are known to discontinue radiation hormonal therapy because of these side effects. Nice guidelines nicely say that in T1N0 patients, if you want to avoid radiation therapy, take a commitment from the patient that they will take adjuvant endocrine therapy for at least 5 years before considering this. Now, realizing that these patients are a good biology, there are several ongoing studies which are comparing partial breast radiation versus endocrine therapy. And in coming times, we will have results of these trials to suggest, to guide us as to how these patients should be treated. For example, this is an EPOP trial where eligible early breast cancer geriatric patients are being randomized to APPI over 5 days with endocrine therapy versus single fraction APPI. So here, 2 modalities. There's another trial, which is again looking at the patient of more than 70 years with early breast cancer to exclusive radiation versus exclusive endocrine therapy with health-related quality of life as their primary endpoint. Hypothesis is that post-operative radiation therapy might help in avoiding the long-term toxicity of endocrine therapy while maintaining equal local control. So I think the mantra in the today's day is stage the age. Don't look at only the chronological age. As Dr. Agrawal said, look at the physiological age. So life expectancy of elderly women are definitely increasing as compared to the previous generations because of the better medical care and increased awareness of the healthy lifestyles. So chronological age alone cannot be an appropriate criteria for decision against or in favor of adjuvant therapy. Among older women with early breast cancer, there are clearly 2 subgroups. Group 1 are fit and active women with life expectancy of more than 10 years, do everything. Give radiation therapy, surgery, chemotherapy, hormonal therapy as per the stage and requirement. Group 2 is the patient with significant comorbidities with limited life expectancy where we need to, customize the treatment plan. And never forget to ask the patient's preference also, because sometimes avoiding radiation therapy can be associated with significant anxiety in these patients. It should not be a default strategy. It should be individualized. I think the future lies in the biomarker-defined treatment approach. The possibility of omitting radiation therapy is being tested in several trials, and we will have this approach in coming times. But I do expect that the coming times will see de-escalated radiation therapy in terms of short course radiation therapy and partial breast radiation therapy for this subgroup of patients, and with probably de-escalated hormonal therapy, either in the lower doses or lower overall duration of hormonal therapy. With this, I think I conclude my presentation, and thank you so much for your attention.
Thanks, Dr. Vinita. That was an excellent presentation. And I hope that the other aspects of radiation, especially in advanced disease as well as in metastatic disease, might come up during panel discussion. So thank you so very much, and please be with us. So we'll move on. Let me invite Dr. Chirag Jain, who is a consultant surgical oncologist at Max Hospital, Vaishali, and Dr. Safalta Bagmar, who is an associate professor of medical oncology at Amrita Institute of Medical Sciences, Faridabad, to moderate the panel discussion. Over to you, Dr. Chirag and Dr. Safalta.
Thank you, ma'am. Good evening, everyone. And we've had 3 very good talks covering surgery, medical oncology, and radiation therapy in elderly CA breast, and leaving very little for the case panel discussion. I also would like to thank all the three speakers for accepting our request to stay back for the panel discussion. Apart from that, I would also like to now welcome on the panel Dr. Anupama Mane. She is Senior Consultant Breast Surgery at Ruby Hall Clinic, Pune, and Dr. Shiveta Razdan, Consultant Breast Surgeon, Amrita Institute of Medical Sciences, Faridabad. I welcome all the five panelists to the panel discussion. We'll now proceed with the case scenarios.
Is my slides visible?
Yeah.
Yes, yes.
Good evening, everyone. So what we'll be doing is that we will be running two cases side by side, two type of case scenarios, which we usually see in the patients who are elderly. So one case, first case is 71-year-old fit lady. She is not having any comorbidities, and she is a gynecologist, and within a week of 1 week back, just he felt a lump and she presented to us. On examination, there was a left breast lump, which was 2 into 2 centimeter of size, upper outer quadrant, and it was not fixed to skin or chest wall. There was no axillary lymph node palpable. Opposite side breast, axilla, supraclav was normal, and mammogram was done that was showing Byrats 4 lesion. And another lady who is 78-year-old lady presented with left breast lump since 2 months, and she was having a medical history. She was hypertensive, she was allergic to paracetamol and multiple stuffs. On examination, she was having a locally advanced disease that was 4 into 3 centimeter lump, upper outer quadrant at left breast without involvement of skin and chest wall. And she was having few axillary lymph nodes. Largest was 1.5 centimeter. And opposite side was normal. Mammogram showed Byrats 5 lesion of left breast with axillary lymph nodes. So I would like to ask Dr. Anupama how you proceed in these two cases. What investigations you will advise?
So obviously we have the mammogram, but we would like to do a core biopsy. Core biopsy for the histopathology diagnosis as well as for the receptor stages.
Sure. Anything else beyond that?
So see, the first case is a Byrats 4 lesion. So I would still wait for the core biopsy report and then go ahead for the metastatic workup if required. For second case, since we are quite sure from the clinical and it's a Byrats 5 lesion, just to save time, maybe the metastatic workup can be done along with after the core biopsy, just to save a few days.
So biopsy was done in both the cases. So in case 1, it was IDC NOS and overall grade 1 with LVI positive. She was having strong ERPR positive. HER2 was 2+, which was negative by FISH. Her Ki67 was 12%. While the second case, it was grade 2, ERPR was positive, and Ki67, 20 to 25%. And FNAC of lymph node was done, which was positive for malignancy. And PET scan was done in both the cases, and it was almost similar to what we have find out clinically. So, and geriatric assessment was done. They were fit individuals with emotionally stable. And the case 2, she was fit individual but emotionally weak with the diagnosis of cancer. So would you like to do any other assessment in these two cases before going ahead with this definitive treatment? Dr. Sanjit? Am I
in
audible?
the first case, probably I forgot the tumor size. So it's a T2 disease, right?
T1 disease.
2
T1.
centimeter.
So it's a T1N0 disease.
Right.
Personally, I would not do PET CT scan here. So I will reduce the investigation here.
Yeah.
And additional investigation, I would like to do USG of the axilla to see the nodal status if I'm thinking for doing sentinel lymph node biopsy for the radiological assessment of the axilla only. In the second case, it's a node positive disease. So yes, metastatic workup. It's a T2N1 disease. So it's a debatable because you said that skin and chest wall was not involved. So it's a clinically CT2N1 disease.
Yes.
So again, metastatic workup is debatable here, but yes, some guideline, European guideline say that in the node positive disease, we need to do the PET-CT scan. Apart from that, we need to do some basic blood investigations and the normal performance status we need to see. You have already said that geriatric assessment has been already done. So I'm not seeing any additional investigation apart from the USG, breast and axilla in the first patient and nothing in the second patient.
Would you like to do MRI in the first patient? MRI breast?
Yeah, means depending upon the mammography findings. So in the elderly, the breast cancer, if mammography is convincing to go ahead with the breast conservation surgery, we don't do routinely MRI in this setting. So it's not very high density breast. So we can go ahead with if the patient want with the breast conservation surgery. I don't remember what exactly in the mammo, but mammo and clinical examination is correlating. So I don't see from my institutional protocol and personal my indication towards MRI in the first case.
Okay, we also did not do MRI in this case. Now, how to proceed? We have seen about question about MRI. Now over to Dr. Chirag.
So my question to the surgeons, firstly, Dr. Anupama, ma'am. So, ma'am, which of these cases, or whether one or two, would you consider for BCS?
So one definitely, because she's a small tumor, and N0, I would consider her for BCS and sentinel lymph node biopsy, the first one.
Right.
The second one, also probably, depending on the breast size, probably she's also fit for BCS. I don't know, because the tumor breast ratio has to be optimal for that.
Right.
So it can be done. Again, discussion has to be had with the patient regarding her choice for BCS or mastectomy. That will also determine, and that's very much a factor here in the second case.
So, I think Dr. Chirag Desai, sir, wants to add something.
Yeah, so in first case, we can go for breast conservation easily, but she is a 71-year-old lady. I don't want to say that she will not opt for breast conservation, but I will definitely say that the fact that she will require radiation after breast conservation has to be discussed upfront. Sometimes it so happens that the breast conservation is done and the patient tells me that if I knew that radiation is required, I would have opted for mastectomy.
Exactly.
So that fact has to be discussed with the patient before planning the treatment.
Right, sir. So regarding the second case, I would like to, again ask the surgeons and the medical oncologist, sir. Would you surgery first or NICT for the second case? Given the scenario of ERPR positive, HER2 negative.
So again, for the second, no, the second case is triple negative.
No, ma'am. It's ERPR positive, HER2 negative. It's the same.
Oh, it's the same.
Yeah.
Okay. So we can definitely go ahead with surgery also over here, as I said, either BCS or mastectomy. And regarding the node, if it is node positive, definitely, then complete axillary dissection.
Yeah. So the regarding the management of the axilla, in clinically node positive, I don't think there's any doubt that if we have a node positive disease, we go ahead with the axillary dissection. In the node negative disease, we go ahead with the sentinel lymph node biopsy, ultrasound of the axilla.
Yes.
Okay. So this is what our patients underwent. The case one underwent breast conservation surgery and a sentinel lymph node biopsy, which reported a single micromet in a node and proceeded with axillary dissection. The histopathology was a T1 tumor unifocal lesion, no DCIS, all margins clear, LVI positive, and single node positive for micromet. The second patient chose MRM, and it was again IDC grade 2, size of 3.5 centimeters, unifocal, no DCIS, all margins clear, PNI negative, LVI positive, and 12 out of 15 nodes were positive, the largest node being 1.5 centimeters without any extranodal extension. So now I would like to ask the surgeon.
Now, how to proceed? What to do with these two patients? So, what adjuvant to be given? What in further evaluation to be done in these two patients? Dr. Chirag, would you like to add something? Any further investigation?
So in the first case, since one lymph node positive, but it is N1 micro, I will not be very keen for doing the multi-gene analysis. I will go with hormonal therapy only. I will not be very keen on giving chemotherapy to this patient. If you look at her Ki67, that also was somewhere around 10 to 12%.
12%, yes.
Yeah, that's correct. So that also is low. Now I'm aware of that Ki67 guidelines that less than 5% no chemotherapy, more than 30% always chemotherapy, and in between go for multi-gene signature, but not for this 71-year-old lady. I will be giving her maybe 5 years of aromatase inhibitor or 5 years of tamoxifen followed by 5 years of aromatase inhibitor, but not chemotherapy in general with N1 MI. So that's for the first patient. For second patient, I will give chemotherapy, 12 lymph node positive and very huge bulk of the disease. But at 78 years, I don't think I will be giving sequential Anthra and Taxane. I will be giving her 4 cycles of TC followed by a hormonal therapy. I might go for BRCA in this patient and olaparib. I don't have any data about elderly patient, and I might give her abemaciclib in addition to the hormonal therapy. Again, I don't remember having any data about elderly patient.
So actually this was discussed with the patient, like in case 1. So she was told that there exists an investigation called Oncotype DX can assist, but if given a choice, I would like to give her only hormonal therapy. But she was like, I want to explore everything that is available, every investigation. I don't want to leave anything. She is a gynecologist and fit lady. So she got done Oncotype DX, and this was the report of the patient. So now what? Dr. Chirag.
Yeah, so recurrence score 27%, and the patient has opted for going for Oncotype DX report. I will honor that. And with 27 score, I will be giving her 4 cycles of TC, followed by hormonal therapy.
That's what. And she also got to know that doxorubicin should be given, but I was adamant. Now I have to keep my foot down that no, 4 cycle TC is good enough for you.
Correct, yeah.
So, yeah. Over to you, Chirag.
Yes.
Yeah, correct. I mean, I agree with that decision.
So I would like to ask Dr. Shweta ma'am regarding the comprehensive geriatric assessment. So what kind of patients actually need comprehensive geriatric assessment, and what should we incorporate into practice in an outpatient department to suitably assess the patient for further treatment in CA breast? Dr. Shweta ma'am.
Everyone, am I audible?
Yes.
Yes.
Yeah. Thank you for inviting me to this panel. So already the previous speakers have talked about something about comprehensive geriatric assessment. What is comprehensive geriatric assessment? It is a multidisciplinary approach which assesses all the old age domains, including functionality of an elderly person, comorbidities, cognition, psychological aspects, polypharmacy, social and financial aspects also. And it helps us to assess the needs of the patient and to start the treatment according to the needs. And according to comprehensive geriatric assessment, we can intervene also and then see the patient, how the patient is going with the treatments. So according to the ESCO guidelines and the International Society of Geriatric Oncology, CGA is now an important aspect of assessing all the patients who are above 65 years of age. As you know, this geriatric assessment is a very long process, and around 45 minutes it takes to assess one patient. So in the International Society of Geriatric Oncology, they have also used simplified CGA assessments. What is included in these CGA assessment, we do activity of daily living or instrumental activity of daily living, like how the patient can the patient eat on its own, can the patient dress on its own, can the patient take bath on its own, can the patient go for shopping on its own, can the patient make meals for himself or herself. So these scores are giving points like 0 to 1. Similarly, in assessing comorbidities, a scoring is given like in Charles risk assessment. So in all these domains, a scoring is given and reassessed after every treatment. So comprehensive geriatric assessment has been validated in randomized trials. We have one GAP 70 plus trial, which was published in Lancet 2021, which says that doing comprehensive geriatric assessment, it improves overall health of the patient, quality of life. It decreases the adverse effects due to chemotherapy side effects, and it does not affect the overall survival as compared to other groups. So it has been validated in randomized trials. So all patients above 65 should have a geriatric assessment, especially above 70 years when the frailty increases. What is frailty has also been discussed previously, that there is decrease in reserves of the body, like the physiological reserves or the functional reserves, and any adverse effect on the patient can have any stress on the body can have adverse effect. In those patients, comprehensive geriatric assessment is very essential. But we can have some simplified geriatric assessments in the clinic, which we can give the patients who can fill them on their own, or the nursing can do it for us. So all patients above 65 should have a geriatric assessment.
Thank you.
What would be the adjuvant treatment in this patient? Case 1 and case 2 both. So Dr. Chirag. So you have already discussed the patient that first patient should receive 4 cycles of TC, and the second patient, if there are no comorbidities as such, like cardiac function is normal and she's fit lady, in that case, she would merit the getting full AC and T followed by T.
So everywhere it is written that age should not be the only factor in deciding the treatment that we are offering to the patient. So keeping that in mind, if the patient is fit, because I have just looked at the number, which is 78 years. I have not seen the patient, so that will make me apprehensive. But if a patient comes walking, climbing the 2 stairs of 2 flights of stair without any problem, I will be giving 4 cycles of AC followed by 12 doses of weekly faculty to this patient.
Yes. And in the low risk patients, there are certain multiple trials that have shown that you can give docetaxel versus CMF. That is almost similar in the older patients, and the toxicity profile, yes, it is different. Then if you want to give Taxol, which was compared with AC, then also it has just given 1% of OS benefit. So these patients who do well with 4 cycles of TC, and it has been compared with AC in elderly patients. And in this trial, almost 16% of the patients were more than 65 years of age. So
Safalta, if I talk about my personal experience without publication, so I feel that docetaxel is tough to the older patient.
Yes.
And if the patient is not having cardiac comorbidities, I will be giving AC to some of these patients rather than TC. 4 cycles.
I have been giving paclitaxel along with cyclophosphamide. I don't give docetaxel to these patients. Few of the patients I have given, and it was really tough to manage. So paclitaxel with cyclophosphamide is very good drug combination for these patients.
Correct.
Would your plan change if the patient is TNBC or HER2 positive in case 1?
So if it is TNBC, I might give only 4 cycles of TC, but if the patient is fit, I will be giving AC followed by paclitaxel, but not dosed in. It will be 3 weekly AC and weekly paclitaxel. And if it is HER2 positive, 4 cycles of TC, that will be docetaxel not carboplatin, but cyclophosphamide, and 1 year of trastuzumab.
So like in APT trial, it was like a patient who are N0 disease, T1, T2, and N0 disease.
N0, yeah.
Yes. So these patients would benefit with APT trial. APT, that is adjuvant paclitaxel plus trastuzumab. So
this was N1, no?
Yeah. So this was N1 micrometastasis. Yeah.
Yeah. So, and the tumor size is just 2 centimeters. So,
yes.
91% of the patient in APT trial were having tumor less than 2 centimeters. 9%
Yes.
were more than 2 centimeters. This is just 2 centimeters. So a borderline case, maybe.
Yes. So we have already discussed about the role of neoadjuvant endocrine therapy, and especially in the case 2, when the patient is very frail, then in that case, we may consider it as like neoadjuvant endocrine therapy, and later on, we may be considering for surgery and like that. If endocrine therapy is alone an option in an unfit individual or a patient unwilling for surgery, so is it there? Neoadjuvant endocrine therapy in case 2, do you feel like?
So we will call it primary endocrine therapy, right?
Yeah.
It's just endocrine therapy alone without going for surgery.
Yeah.
Yeah. So I already discussed that. If the patient's life expectancy is less than 5 years, yeah, surely, why not only endocrine therapy?
And preferred, if neoadjuvant setting in case 2, what would be the chemotherapy protocol which you will be choosing?
Neoadjuvant?
Yes.
Yeah, so it will be, if the patient is fit, as you said, the same, 4 cycles of AC followed by weekly paclitaxel. But in this case, sometimes elderly patient, what I am doing is following the MD Anderson track, giving weekly paclitaxel first. If the patient tolerates it well, then follow it up with 3 weekly adriamycin cyclophosphamide, and then go for surgery rather than the reverse sequence.
Yes, that's what is preferred. Like weekly paclitaxel, you know how the patient will be able to, whether she'll be able to tolerate it or not.
Yeah.
So over to you, Chirag.
Jain.
Chirag Jain.
Yeah.
That's a good one.
So where is Chirag? Is lost somewhere?
Yeah, felt like. So role of RT has been beautifully discussed by Dr. Vinita. So in these 2 cases, I just want to know the brief. What is the role of radiotherapy according to you, Dr. Vinita, please?
So, Dr. Safalta, both these patients are high-risk patients. First patient is high risk because of the high oncotype DX score.
Yes.
The second is high risk because of the high nodal positive.
Yes.
So I would not be keen to offer accelerated partial breast radiation to either of the patients. Although if we go by the trials, none of the trials have used the oncotype DX score to assess their risk of local recurrence, and case 1, as per trials, can still be offered partial breast radiation.
Yes.
But you said that she's only 70 years old, she's fit, her geriatric assessment score is also good. So I would say that both these patients would merit radiation therapy to breast as well as supraclavicular fossa. There is no role of radiation prophylactically to IMC or axillary RT. So the target volume is very clear. And partial breast radiation, in my mind, is also out. So then we are left with only 2 options of radiation therapy. Either it has to be 3 weekly radiation over 3 weeks, or 1 week. Case 1, where only micrometastases are present, I'm happy to give her 26 grain 5 fractions over 5 weeks, which is over 5 days, which is fast forward protocol. But case 2, where it is a N3 disease with 12 nodes positive, I would treat her with hypofractionated schedule of 40 grain 15 fractions with SIB to the tumor point.
Vinita, can I just chip in here? Like you mentioned about high risk because of oncotype DX score. Now, if we see a MINDAC trial also, MINDAC trial says if the clinical risk is low, so the high genomic risk does not have that much of an impact on the outcome. So should we actually factor in just because that information has become available and we have no evidence to say that the local recurrence rate is there's a significant impact?
So that is what I was also trying to say, that, we do not clearly have the evidence to say that the local treatment needs to be modified according to the high oncotype DX score. But then, once you have the information, it is difficult to ignore it also.
No, but there is no evidence to say that the local recurrence risk is increased. And as per all available guidelines, the patient has a tumor which is T1, it is N1 mic. So probably theoretically, if you could say that it is axillary nodal involvement, that becomes a factor rather than oncotype DX, I might have said. But nowadays the recommendation is that it's a solitary micromet, you can as well ignore it.
So N1 micrometastasis is still considered suitable for partial breast radiation.
Yeah, so that's why I'm saying I would say that you should vouch for or maybe vote for partial breast irradiation in the case 1. I would personally be very happy if...
Yes, and this patient has a left-sided breast cancer. So
Yes.
in a left-sided breast cancer, partial breast radiation has still additional advantage of sparing the heart.
And similarly, let me ask you, in case 2, would you be doing internal memory in addition to this?
So there are 3 randomized trials and 1 meta-analysis. None have shown any survival benefit of IMC radiation therapy, prophylactic IMC radiation. So we do IMC radiation only when the node is present. Otherwise,
okay, so that's a very good message. Dr. Chirag Desai, last question. You had mentioned about extended endocrine therapy in case 1. No, that is one element. I thought probably the patient is otherwise a fairly low risk case, T1, N0, low Ki67. Is there a merit for extended endocrine therapy there?
So N1, if we call it N1, then yes. If we call it MIA close to N0, then the answer is no.
Yeah. And generally, when you decide about, say, AI versus tamoxifen at this age, do you take factors like bone health into consideration before taking the decision?
Surely. 2 things. I go for DEXA scan in the patients, and if the patient has a high risk of developing osteoporosis, or if the patient is already osteoporotic, I give tamoxifen. And irrespective of DEXA scan report, I am giving 6 monthly bone
monitoring
agent.
I agree. That definitely. And let me just bring out an issue. We have been talking about, say, geriatric assessment, and Dr. Safalta and Dr. Chirag both showed that these patients had geriatric assessment, which were patients were fit. But let me ask something from the heart, or a realistic assessment. All the panelists. So if you see a patient who's 70 or 75 in your center, do you have a geriatrician available? Do you actually have the capability of doing a geriatric assessment? And I would want an honest answer. Dr. Chirag can answer first because he has to leave probably. So
I already confessed in my presentation that answer is no.
Yeah.
So my answer is also no. So even we have it, it's very difficult to use it in busy clinic.
Anupama, do you have? No.
We don't have, we don't do.
So actually what I would say is probably the cases that were there, I would say it was added more as a theoretical fact that these patients were assessed. In reality, we also don't have a geriatrician in our center. So we rely on our first impressions on the patient. That is a subjective feeling we have developed, and so that is how we go. But I think the message is strong that we should be developing some shortcut tools into our practice so that we can identify patients who need a more detailed assessment. And probably as a group, we should try to develop some consensus on which of these tools would be the best one to identify such patients. So I think that should be an important message here.
Arun, I think that is what exactly Shweta conveyed the message, that we should develop a short, feasible, rapid geriatric assessment in the OPD, which while even nurse who takes the pulse and BP before patient comes to my OPD in 5 minutes, they can do some sort of basic assessment Yeah.
So probably such a tool needs to be sort of identified by a consensus, maybe by our professional bodies, and the message should be disseminated. So we have been going by a sort of just a feel, and rather than using any objective tool. So probably that has to be a very important message which should be communicated. And maybe we should also start collecting some sort of data within our practice, how the outcomes are varying with comorbidities, and also that might actually lead us to improving our practice in future.
So can I ask one question?
Yeah.
Yeah, so the question is to Dr. Sanjeet as well as to Dr. Anupma. Can you please share your experience with operating on elderly high-risk women with in loco-regional blocks, or maybe lumpectomy under local anesthesia? Have you done any?
Yes, so we have done quite a few high-risk elderly ladies under paravertebral blocks, erector spinae blocks, and they've been quite okay. I would say the lower levels are covered very well. Only if you're going higher in the axilla, level 3 in the axilla, sometimes patient gets a little discomfort, and we have to add on a little more sedation and all that. But I think with good anesthetists, it is definitely possible to do any breast surgery under regional anesthesia.
And
very safe also.
Yeah.
So personal, my experience with the local anesthesia or regional block is only with the sentinel lymph node biopsy and in the PEG-B block. So PEG-B block, you can do sentinel lymph node biopsy, but I have not tried a single patient with the local anesthesia. So general anesthesia is very safe now. So even in the elderly patient and the high risk patient, general anesthesia is a safer option. And once you need to go and do the axillary lymph node dissection in the block, it's very difficult.
We did one case recently where we did a breast conservation surgery with axillary dissection because patient was having a CLD, though the INR was okay. So we could do with a block, paravertebral block, and block in the serratus anterior deep fascia. And we could do a lumpectomy plus axillary dissection comfortably, and patient was okay, recovered fully well.
Okay. And maybe another question to Dr. Anupma and Dr. Sanjeev. Dr. Anupma, say in the elderly age group, say above 70, what is your experience with, say, doing a breast reconstruction and doing complex oncoplastic procedures? In terms of your personal comfort, patient offering to patient and patient acceptance.
So I do mention it to the patient because ultimately it is the patient's choice. I do explain the options that they have. But my personal opinion is that the surgery for elderly should be straightforward, simple. Keep it as simple as possible. We don't want any complications.
Absolutely.
These are ladies, they generally develop wound healing issues and other problems.
Absolutely.
So I would tell them not to go ahead for that. But then there are ladies who are very keen for a reconstruction or who are interested in oncoplastic surgery also. So I just feel it's good to tell them about it. Leave it to them, their choice.
Okay. Dr. Sanjeev?
So I agree with Dr. Anupma. So keep it very simple as much as possible.
Absolutely.
So oncoplastic breast surgery, even we offer, it's rarely done. Reconstruction is also same. Even if you offer a patient, rarely if they will go to the plastic surgeon and discuss free flap, definitely they will not be admitted for 7 days or 6 days for the breast surgery reconstruction. Some reconstruction we have done fairly good outcomes. So even if the patient is opted for reconstruction, you can do it safely too.
And have you ever sort of offered neoadjuvant therapy for the purpose of conservation in this age group?
Yes, actually, to the fit patients, yes.
Yeah, you have done, okay.
So in triple negative and HER2 positive breast cancer, in this group of the patient also, neoadjuvant chemotherapy is well enough if you want to do breast conservation surgery.
And maybe
ER positive, HER2 negative, it's a difficult call.
And I just wanted to say, I have a message for Dr. Safalta. Dr. Safalta described the case 2 as a locally advanced breast cancer. So what I would say, Dr. Safalta, T2 N1 with a limited N1 disease in India, we don't call it locally advanced breast
It was
cancer.
N3 or
No, N3 was after surgery, not prior to surgery. Not so unless we have matted notes or fixed notes, I would not sort of clinically N1. It was clinically T2 N1. So in India, we don't call it locally advanced.
I was in that N3 was in my mind that it is locally advanced. One thing I want to add in this case, like in elderly patients, especially when we have just arthritis issues. So in hormonal treatment, we can even go ahead with the exemestane. Exemestane causes this osteoarthritis, osteoporosis sort of thing is lesser. So people do tolerate, and we have the experience for that thing. So if there are patients who are on letrozole and they develop some bone pains and joint pains, in that case, we have changed it to exemestane and they are doing well.
They are doing better. Okay, that's a nice message.
So one question for Dr. Vinita. I hope she's there.
Yes, I'm here.
Dr. Vinita, is there any role of delivering primary radiation to patients who have, locally advanced disease, who are not fit for any chemotherapy?
So, Vaishali, it will be more or less palliative radiation therapy.
So I had one lady who presented at the age of 80 with a fungating mass. And she was not fit for any kind of palliative mastectomy. Neither was she was actually bedridden, and there was a lot of bleeding also. So how to manage such a case?
You can always give her radiation downsize and then consider surgery at an appropriate time point. You may consider this something like preoperative radiation therapy in case upfront surgery or chemotherapy are not possible.
So we can still consider her for that, right? Okay.
If it is not followed by surgery, then it will only be a palliative radiation therapy. The role of upfront radiation therapy is being tested in T1 N0 breast cancers, but it is under trial setting.
Okay. As an alternative to wide local excision.
Yes.
Okay.
Vaishali, abhi you are not out.
Thank you, sir. Thank you. So, are there any questions?
No, I don't think there were any questions in the chat box. So maybe we can.
So I think you have to do the vote of thanks.
Yeah. I think it's my pleasure to give the vote of thanks for this 24th webinar. My thanks to all the faculty, Dr. Sanjeet, Dr. Chirag, Dr. Vinita, Dr. Shweta, all my co-organizers.
And Anupma.
Anupma. Anupma, we always feel like she's our own. She's worked with us previously, so definitely. And
it's more than a quarter-century relationship.
Yes, more than, always wonderful sharing the platform with her. And thanks a lot to Safalta and Chirag for doing a wonderful job with the panel discussion. Thanks, Mice Ideas. And so the next event is going to be, you can see a Silver Jubilee webinar, 25th webinar. So let's see what we can plan for that. We'll come back with it. And we'll also be looking forward to organizing one of the conferences that we do every year. So we've done 2 in the previous 2 years. So this year also we'll be organizing a virtual event. And I must say that I am sold on this idea of virtual events. They need not be very long, slightly shorter, but it's an excellent opportunity to bring people from all over the country and other parts of the world together. And the audience also can be from so many different places. So thank you once again. Happy New Year once again. See you again.
Thank you.
Thank you to all.